Hello and welcome to our IVF webinar tonight. I hope you can hear me well. Dr. Vanessa, hi, how are you tonight? And you can hear me, I understand, of course, as well.
Hi, Caroline. How are you? Hi, everyone.
Perfect. Thank you so much for confirming this. I just want to make sure because some of you might know that this is our first event tonight, as the previous one we needed to reschedule. And if just to remind everyone, we will be able to send you the new date very, very soon. So stay tuned and don't worry, we'll definitely connect with Dr. Ramon as well. But tonight we have another topic to tackle. And so, of course, we will have a presentation from Dr. Vanessa. She will explain the details, and her presentation is on key components for improving success rates over the last years. And Dr. Vanessa Vergara is actually a medical coordinator at IVI, which is located in Valencia. Hello, it's good to have you here with us. Thank you for joining our Stronger Together event. And let me just remind everyone that we are meeting here every single day, twice a day even, so that you can ask your questions to top fertility experts and just learn and ask the questions that are bugging you, I am sure. Since you are not able to proceed with your treatments right now, we definitely want to give you that opportunity to simply get ready for the treatments. Some of the clinics are reopening, and we are all waiting for that. So remember, you can ask your questions, and Dr. Vanessa will be able to answer them for you as well. And all the events has been brought to you thanks to our ambassadors and partners. You can see them right here. So again, huge thanks to them for helping us with this initiative as well. And as I've already mentioned, we will start off with the presentation. Dr. Vanessa said it will take approximately 25 to 30 minutes, and after that, our Q&A session will follow. All you need to do is type in all your questions in the chat section, and Dr. Vanessa will simply answer them for you. This is recorded as well, and you will still have a chance to watch it soon on our website too. And that is it from me at this point. Dr. Vanessa, and you're ready to begin with your presentation.
Thank you, Caroline, for this kind introduction. For me, is an honor to be here, talking and trying to give more information and support to all our patients. We understand that it's a need for patients to be informed, and in these days of COVID-19 pandemic, it's very important to be aware of a lot of things, and patients need more information, especially in the UK, Spain, United States, all over the world. We have seen so many patients and families that have been affected by this disease, and we understand how supportive we need to be. However, there are some places like Spain right now where the new cases, the workload in the hospitals, and the deaths, of course, are seen to start to be under control. So we are prepared to start over and with very strict protocols, and to give all the support to the patients and to their families when they pass through this fertility treatment in these times of COVID-19. We have changed a lot of things to have safety protocols, and you can ask anything about COVID-19 if you want, and if it is in my possibilities, I will answer those questions. So I'm going to start today talking about the key components for improving IVF success and the rates over the last years. Okay. Let me move this. We have different types of protocols that we have in our clinics, and one of the most important of them is protocols to follow regulations. We have local and regional regulations for the IVF treatment. The regional regulations are those established by European directive, and the local ones are established by laws and regulations of every country. We have different types of regulations in the United Kingdom, different types of regulation in the United States, in Spain, Portugal, Italy, everywhere. We have some specific situations or conditions that establish what type of treatments are allowed. Specifically, what type of treatments are allowed in every country. So when we talk about success rates, first we have to define success. When the major objective of an IVF treatment or an egg donation treatment, even if the treatment is with eggs, with own eggs or eggs from a donor, is for a patient to have a healthy child at home. However, there are many steps in the process of IVF treatment that we can measure, and we can see how good enough we are doing every step of the process. And that's why we have different indicators, as, for example, the implantation rate, which I'm going to explain later, and for example, the number of blastocysts or the proportion of blastocysts that we can create from a number of oocytes also defines us how good is our IVF lab working. And at the end, our only purpose with this is to have a healthy child. That's why live birth child is our major objective. So as I said, we have different indicators. All of them are based on research and innovation, but we have two main lines of how we divide these indicators. Those lines are the IVF lab and the clinical line. In the IVF lab, we are continuously improving techniques, measuring our techniques, having new equipment and new technology. We have a lot of lines of investigation, and of course, the training of our embryologists. In the clinical part, the indicators are based on a deep understanding of the physiology, the individualization of the controlled ovarian stimulation, and of course, the experience of our clinicians. These things play a relevant role in our outcomes. So how we measure outcomes? It is interesting for patients to see this because there are a lot of terms that we talk about in fertility clinics that we need to explain how we get them. For example, the implantation rate. The implantation rate is the number of sacs that we see in the first ultrasound of a pregnancy divided by the number of embryos that were transferred. It is very different from a pregnancy rate because a pregnancy rate doesn't take into consideration the number of embryos. The pregnancy rate only takes into consideration the procedure of the transfer. So when we do single embryo transfer versus double embryo transfer, it is important to see how we are going to compare those two types of transferring. If we transfer one embryo, or if we transfer two embryos. So another outcome, which is very important, is the ongoing implantation rate or the ongoing pregnancy rates. Is how many of those embryos that we transfer continue developing correctly through the pregnancy and reach a level or stage in the pregnancy of more than 12 weeks. And of course, the live birth rate, which is the number of births divided by the number of transfers. The cumulative rates is something that we have always to take into consideration, especially when we do single embryo transfer. This is something that I'm going to mention a lot today because it will be very, it will have a special weight in our results of live birth rates. So we have different consensus on international guidelines of how we should measure the outcomes in the IVF lab or the clinical outcomes. Those consensus give us an average objective that we should meet and also give us our main goals of what we should reach to in an IVF clinic. And also we can compare us with others. Fortunately, in EV, we have many clinics, and it is kind of easy for us to compare and to see with audited results how good we are doing something in a specific step of the process. Also, we in medical affairs of EVRMA headquarters, we set annually, yearly, we set new goals, new objectives for many indicators. So as I said, we have different type of protocols. Number one, protocols to follow regulations. Number two, protocols to practice safe medical procedures, which now in times of COVID-19 are very, very important. And protocols to improve outcomes, which are the ones that I'm talking tonight about. So we have different strategies to improve outcomes based all of them in research, and the ones in the IVF lab are based on having the best possibility of embryo selection. I'm going to explain that, and the best option for embryo culture. And in the clinical side, we should have individualized ovarian control ovarian stimulation protocols, luteal phase support, and how important it is for us now to do single embryo transfer. That's why we have to do the best selection of our embryos. So here in this graphic, you can see how we have improved our outcomes, our implantation rates through the years, in the last 15 years, and we have very key changes that have make us to have this improvement. This improvement that you can see here is in the blue line, you can see the own eggs, and in the orange one, you can see the egg donation, the cycles with egg donations. These cycles with own eggs are without PGT. And from 2006 to 2011, we can see here, we start to have less patients per incubator, standardized protocols, and we gradually started to introduce the benchtop incubators. I'm going to explain what impact it had really in the outcomes. In 2017, we had 100% of our incubators of the benchtop type, one patient per incubator, and this permitted us to have policy that we were going to transfer all the embryos in blastocyst stage, 100% blastocyst stage transfer. The benchtop incubators permitted us to have the best conditions for the embryo, as low oxygen, for example. We have always believed in PGT, in pre-gestational testing for aneuploidies, but in the last years, we have been indicating it for a maternal age systematically, with advanced maternal age or maternal age over 35 to 37 years old. Of course, taking into consideration specific regulations of every country, because, for example, in Spain, we can do PGT-A or testing for aneuploidy in the embryo if we have an indication. In this case, would be maternal age over 35 years old. But in egg donation, we don't have that indication of maternal age because all our donors by law are younger than 35 years. So we should have other indication for PGT-A for gestational diagnosis or testing, as, for example, recurrent pregnancy loss or severe male factor. Also, we started that puncture in blastocyst stage led us to do the biopsy at that stage, which is better for the implantation rates. And that is selecting a good embryo with all these techniques led us to do the single embryo transfer almost in all our patients. We started gradually, especially in patients over 44 years and then patients of all egg donation. But now if we have an euploid embryo, that's what we try to do. In this graphic, you can see how we improved our outcomes 20% in all the ages. But you can see here how there is a drop independently of that improvement. There is a drop after 40 years that if we don't, and these are cycles without PGT, look at the title please, because if we don't analyze that embryo, we cannot avoid that drop at the that makes a fall in the outcomes after maternal age of 38 years. In this graphic, you can see how this doesn't happen with the cycles with PGT. We have improved a lot. This is implantation rate. Remember what is implantation rate? Implantation rate is the number of sacs that we see divided by the number of embryos that we transferred. And it is pretty high in 2020, 2019, 2020. This yellow line is from 2017 because the results and outcome doesn't change every year. So you can see here that we have like groups of years while we have this evolution. And the PGT make us the possibility of, after transferring an embryo, after getting an euploid embryo or a chromosomally normal embryo, to have the same rates through all the maternal ages. The problem is that with advanced maternal age, it is harder for us to get an euploid embryo. And that graphic looks just like the one of egg donation rate. The egg donation we have been improving the results, the outcome in cycles of egg donations, and we started to see this with the IVF changes even before we saw this with the own egg cycles. So we did a lot of improvements in embryo culture. We passed from big incubators where we had many patients before and to benchtop incubators. Benchtop incubators, you can see, are little incubators where we have very, very small chambers and we have one patient per chamber. And this made us to have more stable conditions with low oxygen and these conditions allowed us to have better culture, more and better embryos. And that's why we can pass to the 100% blastocyst transfer policy. So the blastocyst stage transfer made us to have more selection. We have new technologies that we introduced to our labs, like time lapse, where we use more data, artificial intelligence to select using morphokinetics characteristics of the embryos, which embryo is the best one. And this allowed us to do the PGT diagnosis or the PGT testing, the PGTA, with blastocyst stage biopsy. And we have more information about what embryo of the group is the best. And this made us to possible the single embryo transfer strategy. So we in IVI clinics and in as many groups in the scientific community, we do believe in the benefits of the pre-implantation genetic testing for aneuploidy, which is called PGT-A. Previously, it was called PGS. And not only because we have better implantation rates per embryo transfer, but also because it is cost effective. At the end, when you have to add all the things that you have to do, it is cost effective. This is a study published by our group in 2018, our group in New Jersey. It shortens the treatment time and it reduces the risk of failed embryo transfer and clinical miscarriages. These things are very important in the psychological way that the patient is going to handle this, because it's not the same when you have so many failures, have a clinical miscarriage, which you have high possibilities if you don't analyze that embryo and if you don't transfer an euploid embryo. Okay. We can see here in 38 to 39 years old, this group of patients, you can see how different the outcomes are in the group of IVF or this IVF genetic, which is our program of PGTA. So this, you can see here that we have more transfers. Of course, we have more transfers if we don't analyze those embryos. But when you have the euploid embryo, then your clinical pregnancy rate goes from 44 to 56%, which is a pretty high increase in this age. And we have one of the things that I consider more relevant is the miscarriage rate, which goes from 18% to 11% if we analyze those embryos. There are some pregnancies that even though we analyze the embryos, we are going to still have a miscarriage, and even after analyzing. And of course, the increasement of the live birth rate per cycle. And in patients from 40 to 42 years, we can see the same difference or the same proportion of difference. We have less embryos to transfer because we get fewer euploid embryos, but we have a high, higher clinical pregnancy rate that goes from 35 to 56%. And we have a miscarriage rate that goes from 30% to 11%. This is important because the principal cause of miscarriages is the aneuploidy, or the chromosomal abnormality of an embryo, and that's why this 11% is almost the same in young patients or in patients over 35 years old, if we have the opportunity to analyze the embryos. So you can see here the pregnancy rates per transfer, how they remain stable independently of the maternal age, because of course we got the euploid embryo. If we don't get the euploid embryo, and that's why the pregnancy rate per cycle, when we talk about cycle, we are talking about the retrieval. And if we don't get, considering that when you have advanced maternal age, you are going to get fewer euploid embryos. And that's why the rate per patients that starts treatment goes lower with the maternal age. But once you get the euploid embryo, the rate remains high. With the miscarriage rate in the graph on the right, you can see that without PGT, the miscarriage rate goes higher with the maternal age, but with PGT, which is the light blue on the left, it remains pretty stable, independently of the advance in maternal age. The introduction of blastocyst stage biopsy was very important. Was a milestone that we had, a remarkable thing that we did some years ago, because before that we did biopsies on day 3, and now with the all the advances that we have in the vitrification and thawing of embryos, and the possibility of doing a very good technique with the biopsy in blastocyst stage, we have a lower possibilities of doing an impairment to the implantation potential. You can see here in blastocyst rate, the potential of an embryo for implant is almost the same. And in the cleavage stage, after you do the biopsy, it is not the same implantation potential. This is also a paper study from our group in 2013 in the group of New Jersey. So all these changes in the IVF lab allowed us to have the policy of single embryo transfer. I'm going to explain how important this is for us, because the implantation rate is the same, as you can see. It was 2016. I have to clarify this. It was 2016 because it was the last time where we had enough cycles of double embryo transfer where we can still compare them. Now we don't do double embryo transfer. At least we try, don't do. And that's why we don't have a newer or more recent statistics about that. The implantation rate is the same in both groups because it depends more in the embryo. And the pregnancy rate, you can see that it is a little bit lower if you transfer one embryo. But the benefits that we are going to get are remarkable, and we have to compare the cumulative pregnancy rate. It means that I have to compare what happens when I transfer one embryo at a time, and if we don't get pregnant, we transfer one embryo in the next, in another treatment, in another procedure. This is comparable to what we have here of 50% of the pregnancy rate if we transfer two embryos. And why we do this is because we want to reduce the possibility of multiple pregnancy or twin pregnancies. So it is 38% the possibilities. It is 38 possibility, 38% of possibility of having twins if you transfer two, and almost 0% if you transfer one. The egg donation, is almost the same proportion. We have it is the same, almost the same, even though here we can see 56 versus 48. They're not necessarily statistically significant. And we might have the same implantation rates, but we have to compare this 66% of pregnancy rate when we transfer two embryos. We have to compare it with this 70%, which is the cumulative rate of transfer two embryos, but in two different steps. And why? Why are we doing this? We do this because with double embryo transfer, we have more possibilities, around 40% of possibilities of having twins or of having a twin pregnancy. And these have a lot of complications, fetal complications, uteroplacental complications, maternal complications, and complications of the newborn that can persist through childhood or even later. Fetal complications are complications of in the fetal growth, intrauterine growth restriction, abnormalities in the presentation, uteroplacental complications, placenta previa, abruption, or bleeding after the delivery. Maternal complications as hypertension or diabetes, and premature labor and birth. And for the newborn, the principal complications are based on the risk of premature delivery. We also have, after all our strategies in the lab, after all our strategies of analyzing and selecting best embryo, we do have clinical strategies that we implement in our clinics after a lot of studies of our group or things that we see in other groups or in other investigation groups that works and are going and really helps, because there are many things that exist there and you can see that don't really help and sometimes they might be harmful. And so we have to be very sure of what we are doing. This is an example of how clinical strategies we hope to change and to increase our rates. This study of Elena Labarca from IVI Valencia shows us how the progesterone level on the day of the transfer in patients of egg donation is important if it is lower than a cutoff of 8.8 to 9.2. If it is lower, we have to look for a different strategy of luteal phase support, because those patients are going to have a lower ongoing pregnancy rates. They have more possibilities of miscarriage. And with the serum progesterone in a level over 9.2, we have the same ongoing implantation rate. We introduced this last year, in 2019, and we hope that all the strategies that we have to improve luteal phase support after having this information will improve our ongoing pregnancy rates. I mean ongoing pregnancy rates in pregnancies that pass over the 12-week pregnancy. And we always mention at EVI the cumulative rates per cycle. It means that we have a cycle with an egg donation cycle or an own egg cycle, a retrieval. That retrieval is a cycle, and is what we call a cycle. And we do the fertilization of those oocytes. We create embryos, and we are going to transfer those embryos one by one after properly selecting them. And that's why for us, to measure how efficient the cycle, the donation, or the retrieval is, we have to look for the implantation rate or the pregnancy rate of all the embryos that we got in that cycle, not only one transfer. We still have a lot of clinical challenges, but we are working on them. We are doing research every time. We are analyzing data and seeing how safe and how efficient some treatments could be. So considering that maternal age is the most important factor that affects quality of the oocytes, all our efforts are here to improve these two aspects. Our possibility of obtaining an euploid embryo highly depends on the number of mature eggs that we can retrieve. Support responders are still a clinical challenge. And I know that many of you are going to ask a lot of things about this, but all the approaches that have been developed in the last years may look promising, but there is still a lack of evidence in many of them. We have remarkable things that happened for us as strategies to have more oocytes available for an IVF. One of them was the accumulation of oocytes that was possible because of the high survival rates that we have after thawing the oocytes. And it made us the possibility to do accumulation of oocytes to get more for an IVF cycle. Duostine is another promising strategy where for patients with a low response or low ovarian reserve, where we are going to do two ovarian stimulation during the same month. The first one in the follicular phase, as always, and a few days after the retrieval, we start a new stimulation. So what we do is we identify the poor responder. We do the individualization of the ovarian stimulation, of the control ovarian stimulation, and we do the best approach in the IVF lab. These make us to have the best transfer and, of course, the best luteal phase support. As I said, we have a lot of things that we don't know yet, and we try to do the research and everything all the time. We have many lines of investigation as female fertility, IVF clinical, IVF lab, technology development, and pre-implantation genetics. So if you have any question, I am open for that now.
Perfect. Thank you so much for your very interesting presentation. Excellent presentation indeed. Lots of useful information, lots of details with lots of data as well. Thank you so much for that. And yes, it is time for our Q&A session. We do have a few questions ready. So let's get to it, Dr. Vanessa, okay? Dr. Vanessa, can you hear me?
Here, yes, here I am.
Okay, perfect. Thank
I'm
you so much.
sorry.
And let's go for the very first question right here. Do you use time-lapse incubators and do you believe that they make a difference?
Yes, we use time-lapse incubators. It is a very interesting tool that we introduced few years ago. It is a tool that we have to select better embryos. We use it and we find there are a lot of studies that find good results. Some studies are not. So the evidence, the scientific evidence is kind of contradictory, but it is an incubator. It is an incubator that permits us to have a that has very interesting strengths, as for example we can see what's going on with the embryo without opening the incubator every time. And also the we use it, but I cannot tell you how big was the impact of these incubators in the long-term advance increase in the results that we had during time. But of course, there are many studies that establish that we have some benefits.
Perfect. Thank you so much for answering that very first question. And next question is right here. What is the difference between PGTA and PGS?
Okay, PGS is it is the same. PGS is just the previous terminology that was used. I cannot remember if it was 1 or 2 years ago where the international nomenclature changed and we proposed the PGTA as the name of pre-gestational testing. This pre-gestational testing could be of aneuploidy to see the chromosomal abnormalities of the embryo, or it could be PGTM, which is the diagnosis of monogenic diseases in the embryo, or it could be PGTSR, which is the structural identification of chromosomal abnormalities in the embryo. But PGTA and PGTS, it's the same. It's only that PGTA is the newer term that we use for that same thing.
Excellent. Thank you so much again for explaining this to us as well. Okay, next question is up here. I am on anti-seizure drug called lamotrigine because of a car accident, frontal lobe. Does my medication make IVF more difficult, less successful?
Okay, it doesn't have to. The problem with the drugs is that we don't exactly know the exact teratogenic effect that is going to have. So when we have these cases, we have a multidisciplinary group of specialists who and a special a person who has a specialty in maternal fetal medicine, and we do we have this clinical special cases committee where we analyze all the recommendations of the neurologist. We have the recommendations of the obstetrician of the maternal fetal medicine. We don't. I don't believe that they right now we have evidence of teratogenic effects with this anti-seizure drug, and which is the most important. And for the thing of the transfer and the results of the pregnancy rates, it won't have any impact in that. So my only concern would be the teratogenic effect. But as far as I know, this doesn't have. So the benefits when we have these type of drugs, we have to compare, and we talk with the neurologist about the benefits of using the medication or stopping it. And of course, all these medications have a very important indications. So usually we give them because there are no clear teratogenic effects. If we see a clear teratogenic effect of an anti-seizure drug, we have to stop it. We have to do plans with the neurologist and change. But it won't affect the results of the IVF treatment.
Perfect. Thank you once again for explaining this to us as well. Next question is, I am interested in your 100% blastocyst transfer. I have read that some women cannot produce blastocyst. How do you manage those patients?
Okay, it is the thing with blastocyst is that we have to provide the best environment to the embryo, and we are sure that we have it. If a patient cannot get to blastocyst blastocyst stage, of course we can discuss options of transferring in day 3, but we find no benefit in this. We really don't find any benefit transferring embryos before, because if they don't survive in the laboratory, they will probably don't survive in the maternal uterus. And that what would happen would be that this will result in a negative pregnancy rate. This is the thing is that if we don't reach to that stage, there's few things we can do. What we do now is that we try to have more available oocytes and give them the best environment in the IVF lab.
Okay, again, perfect. Thank you so much for your question and your answer. So you would recommend to transfer only one embryo when receiving egg donation?
Absolutely, yes. We always recommend transfer only one embryo because, as I said, we have a very high implantation rate, which is going to give us the pregnancy rate when you transfer just one embryo. And the possibilities of twin pregnancy are nearly zero, and we are going to avoid all the complications that I mentioned. So I am absolutely sure that we recommend transferring of a single embryo transfer.
Okay, perfect. Thank you so much again for explaining that. All right, next question is, I am in the UK. I feel very conflicted about PGTA testing, given that the HFEA advises very much against it, agreeing that there is no strong evidence for its use.
Yes, I understand that. What we have to look at here is what a patient wants and the feelings and how the PGTA is going to improve. The arguments that HFEA uses is that when you have the retrieval, when you have the retrieval of your oocytes, you are going to have, if you consider, imagine that you have 6 oocytes, and you happen to have 4 embryos. If we do PGTA, we have the opportunity of getting that pregnancy in the first one. Very, very high opportunities. And what happens if you don't have PGTA is that you're going to have to transfer embryo number 1, embryo number 2, embryo number 3, and embryo number 4. And after transferring 4 embryos, at the end, you are going to have the same possibilities of a live birth, but per cycle, it definitely shortens the time that you need to get a pregnancy, and it lowers the miscarriages rates. There is no doubt of that. So I understand why, because in terms of public medicine and those things, it's kind of hard to say that it is going to improve the live birth rate per retrieval, because it is not going to improve that. It is going to improve the live birth rate per transfer dramatically, and it is going to shorten the time that you need to get pregnant, and it is going to lower the miscarriage rate. If you are over 40 years old, you have a miscarriage rate of 30% without PGT. So you're going to pass all these for a 30% possibility of miscarriage. And it is very different from a miscarriage, from an 11% of miscarriage of younger patients. And that's what we reach when we find a euploid embryo.
Perfect. Thank you so much again for all those details you have just provided. Next question is, why would P4 level be low on the day of embryo transfer? Is it something to do with different people absorbing progesterone differently?
Yes, it is. It is not well known the exact reason. I wish we have that answer, because progesterone has been a part of many researches and many investigations. But it depends on the way we are administering that progesterone. There are many types of routes of administration of progesterone. We have the intramuscular one, we have the vaginal one, which is the one that is preferred in Spain, but there are some groups in the United States that prefer, for example, intramuscular, and now we have the subcutaneous injection of progesterone. And yes, many people have a different absorption of progesterone vaginally, and which is our preferred route of administration, and we have to add some other route of administration of progesterone, like, for example, subcutaneous.
Perfect. Thank you so much once again for this explanation. And the next question is here. What dose of vaginal pessary progesterone do you prescribe? 600 milligrams or 800?
We use 800 milligrams progesterone.
Perfect. Thank you.
For the cycles, for the egg donation cycles, or cycles where the patient doesn't produce any progesterone. If you have an IVF with own eggs, and you go transferring that embryo in that first cycles, the luteal corpus of the ovaries produce progesterone. We do have to give some support, but it is not as high as 8 milligrams, at 800 milligrams, I'm sorry.
Okay, thank you so much again. And for dual stimulation, how many days after first egg retrieval do you start second steam? 3, 5, 7, 9 days?
It is from 3 to 5 days, after the first retrieval.
Okay, good, thank you. And I am planning to do budget egg donation program. It's 12 frozen oocytes from 2 different donors, 6 from each. For example, also use sperm donor. I'm 38, 5 failure IVF with own eggs. Doctor said I don't need PGD in case of egg donation. What is your opinion on this? Isn't it better to not fail again and not to transfer wrong embryo again? Also, I really want to transfer 2 embryos. Is this risky? Too risky?
Okay. This is, for me, this is a very easy question to answer because, first of all, I don't understand why you're going to have two different donors. I don't necessarily agree with this approach, but I don't understand why in your clinic they are doing that, and I respect that. We have the donation of a good number of oocytes from one donor. We have a very good fertilization rates with sperm donor, so it's I do agree. Oh, it says
There's a
it's
follow-up question. Yeah, I mean, additional information.
okay. Okay, I understand that reason, and it's I understand that. But even though with six oocytes, we have a good fertilization rate and a good rate of having blastocysts. I What your doctor said that you don't need PGD and PGS in case of egg donation and sperm donor is true depending on what country you are, because it is not that you don't need it. Of course, if you do PGT for egg donation, you are going to have more possibilities of euploid embryos. But this is not absolutely clear when the age of the donor is less than 35 years old. So in countries like Spain, it is not allowed by the regulation on the law that I explained at the beginning. We don't have an indication of a PGT when we have, of PGT, PGS, how you explain that, when we have an egg donation and when we don't have any male factor. So it would be better not to fall again, transferring the wrong embryo. Yes, it will be better, but I'm not sure if the regulation would permit it. That's the thing. In other countries, in Spain, I am so absolutely sure that we can't do that. Treatments in UK, Ukraine, and all donors are 20. How could you please?
Yes, this is additional information from the very same patient. Yeah, so that it's done in Ukraine.
20 to 28 years old. It's the same. The law permit us to do donations if our donors are younger than 35 years old. It is from 18 to 35, and we have very, very good results with those in that range. And if they have that range in Ukraine, there will be a specific policy of a clinic, because I don't think that is a type of regulation, because we think that we are going to have more aneuploid embryos or something like that at that age.
Okay, thank you. There's also a follow-up, once again, question: is this less success rate because it's two donors?
No, I don't think so. I don't think so. But it's just that imagine that that you have a one donation with 10 eggs of one same donor. You have 80% of possibilities of having more than one blastocyst to transfer. So you're going to transfer one, probably you're going to get pregnant, and maybe in 2 or 3 years you will want a sibling with that same donor. And if you use different donors, then things are not going to be so easy. We never do that practice.
Okay, perfect. Thank you so much again for this. Next question is up. What is your opinion on ERA test? How valuable is this information, and can the receptivity change in time? How long is the result of ERA test valid? Lifetime or a certain time?
Yes. ERA test is an option to evaluate the endometrium, how the endometrium is going when we have patients that have failed in previous treatments. Imagine that we have very good embryos that were transferred, and they were euploid embryos or embryos from an egg donation, and we don't know what's going on. We do the ERA test to see the window of implantation of receptivity of that embryo, and it helps us to set to give more time of progesterone or less time of progesterone to get to fit our patient in that specific time where the endometrium is more receptive.
Okay, perfect. Thank you so much again. I'm thinking of using egg donation at EV Barcelona. Do all EV clinics have the same equipment, incubators, and protocols?
Yes. I work in medical affairs. I try every day really hard to with all the medical affairs team to have the same protocols in all the clinics and the same equipment. In EV Barcelona, they have excellent results, and we do benchmarking of all our outcomes every month. So this is something that you can be sure about.
Excellent. Thank you for that, and reassuring as well. Thank you. Okay, and what do you recommend to support enhance the implantation process? Any extra medicines beside progesterone, supplements, acupuncture, anything else?
Yes, it's very uh, really difficult question, because I know that there are some things in that may help, but there is no strong evidence with any type of extra medicine after the transfer. So we don't recommend supplements except folic acid, for example, but we don't recommend any other supplement, acupuncture, nor anything else. It is true that some years ago there were studies that said that the acupuncture favor the implantation, but we don't do that anymore, and we don't recommend it.
Okay, thank you again for that. And we actually have a follow-up question on the ERA test. Okay, if you could take a look, could you please extend your answer to the ERA test? How valuable is this test in your opinion? Can the receptivity change in time?
I cannot answer that question. I don't know if it's going to change in time, but we think that it won't, because the ERA test is based on the expression of genes and how your body reacts with some medication to the expression of genes that may favor. So I don't have anything that can make me think that it's not going to be valid. If you receive the same medication in 1 month or in 6 months, I hope and I understand that your endometrium is going to respond in the same way.
Okay, excellent. Thank you so much again. I'm considering twins. Do you think that that would cause a complication, as I am 44?
Yes, yes. It is not recommended to look for a twin pregnancy at any age. And if you're over 40 or over 44, you have more risk of complications as preeclampsia, diabetes, premature delivery, and fetal growth restriction. So I won't recommend that. Uh, you should go after. You should go for one single embryo transfer, and after that, if you're happy, you can go for the next treatment a couple of years after that. But it is not necessary to add that risk to a treatment.
Okay, perfect. Thank you again for this. And next question is, are differences in progesterone quality absorption depending on the kind of administration, intramuscular or versus oral or vaginal? Any of them is better than other?
Okay, there is no specific answer for that. All the ways of administration are seem to be good. We prefer the vaginal way of route of administration because it doesn't hurt, because the intramuscular hurts and it has to be injected daily. So we prefer that. In some countries and in some group of clinics, like in the United States, there are a lot of groups that prefer using intramuscular. The studies right now doesn't seem to have any big difference between the different routes, and vaginal route works pretty well.
Okay, excellent. Thank you again for this. And I was receiving 1,200 milligrams of progesterone 3 times a day, 2 capsules. Is it too much? I was not feeling very well when taking it with no successful implantation.
Okay, first of all, it will be interesting to know why you were receiving that high dose of progesterone, because it's not the normal dose that we use. Maybe because your doctor have seen a problem in your previous treatments, or 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 maybe a serum progesterone level that was not okay, and they didn't have any other option, or you were not tested. For us, it's not the usual way to start a treatment, and we do that in anecdotal situations where you have where patients have very low progesterone levels while using it in the luteal phase during the luteal phase support.
Okay, thank you again for explaining that. Okay, let me check. Okay, patient also has added that my natural progesterone was okay. Yeah.
Yeah. Yes.
Okay, thank you. And let me just go back to the question. Okay, here it is. Sorry. Is every IVF pregnancy a risky one? Are there higher risk to lose the pregnancy with donor eggs than with own eggs?
Okay, let me check. Is every IVF pregnancy a risky one? Are there higher risks to lose the pregnancy with donor? No. Not all the IVF pregnancies are risky ones. The studies on the obstetrical outcomes if you transfer one embryo are the same with natural and IVF pregnancies. And there are no higher risk of losing a pregnancy with donor eggs. As a matter of fact, considering that the donor is younger than 35 years old, you have a lower risk of abortion. If everything is okay with the uterus and you have no other complications, you don't have more risk of losing the pregnancy.
Okay, perfect. Thank you so much again for this. We have like two parts of it. Okay, so we were lucky to have a baby 5 month old from last year's fresh embryo transfer, even though I'm in menopause. And the next one is here. We still have 3 embryos left for frozen embryo transfer. We're trying for another one when COVID is better, since it's in Prague, but we're from the USA. How will the doctors know which one is the best to transfer?
Okay. These frozen embryos that you have, it will be very important to know if they are on day 3 and day or day 5, if they are in a blastocyst stage or in a cleavage stage. We have physical characteristics of the embryo, morphological characteristics of the embryos, and they choose the best considering, okay, they are in day 5, they are blastocysts, so they have morphological characteristics that the embryologists are going to check. If they are from egg donation, probably they don't have any PGT done, so it's only based on morphological characteristics of the embryos.
Okay, thank you again for
And I
that.
hope that you can travel from US to Prague really soon, or not so far from now, because yes, you know that thing of the COVID-19 pandemic is making us to have too much trouble with the travels.
That is true. We are definitely all waiting for that. So fingers crossed it will happen quite soon. Okay, perfect. Thank you so much for that. And next one is, how do you select your donor? Is it based on finance or voluntary? What are the ethnicity? Any blacks? If yes, where are they from?
Okay, we have a very strong program for selecting donors. We select the donors because it is a voluntary act, and they come here because you may know that Spain is the number one country in the world for organ donation, and for that same reason, the donation of tissues and cells is very, very well seen by society, and they are all altruistic girls that come to give their eggs to other couples. Uh, in Spain, it is not allowed to pay for the donors as it happened in other countries. So what we can do is have some compensation for all the inconvenience of going to the clinic and the travels and everything, but we cannot pay. So everything is voluntary, and it is an altruistic thing that moves this person to have to give the donation, and the ethnicity depends only on the ethnicity of the receptor. If you're Caucasian, you're going to get a Caucasian donor. If you are African American, you're going to have an African donor. And if they is black donor, yes, we do have black donors, and they usually come from Africa and from our people, immigrants that comes from Africa to Spain, and they live here.
Okay, perfect. Thank you so much once again. Okay. Do you have better results, any proven results that the pregnancy was achieved after adapting the transfer, the ERA test result?
Yes, we have better results, and it depends on how. Uh, in some studies show that we have good results, and some studies show that they don't that you don't have. We recommend it when you have a recurrent implantation failure after transferring good embryos and after studying for everything else, because we should have any some information about the if the endometrium is receptiveness. And yes, we have a lot of cases where we have used it, and after that the things have changed. So it's a tool that we use, and we recommend it.
Okay, perfect. Thank you once again. We have one question left actually, so just let me make sure that everyone, if you have any more questions, just go ahead and type it in. And there is another question right here. Okay. Yes, we can't wait to travel. I have read stories of people transferring a PGTA abnormal embryo but then having a healthy child. This does concern me. How could this happen?
Okay, this is a very, very hard question because it is not exactly a PGT abnormal. It is how you do the diagnosis with that PGT and how does the genetic lab, do the interpretation of those results. What had happened in the last years is that the technique, the next generation sequencing, is able to see the mosaic embryos. I think that you could be talking about that, and these mosaic embryos um, have an implantation potential, and they do have the potential um, of, of giving a healthy child. We have changed that policy during the years, and after deep genetical counseling, we are transferring mosaic embryos. Mosaic embryos is just that all the cells in the blastocyst are not the are not of the same type, and it seems that the embryo have the opportunity and is able to grow and give a healthy child, even though you can have more than one lines of chromosomes in the cells.
Excellent. Thank you so much. Right now, it looks like we will be finishing, and there are no questions left. So thank you so much to all of your questions. And well, Dr. Vanessa, thanks so much for again answering all those questions in detail. And well, there are some patients that also found it very useful, very helpful answer. Thank you. Another one is thank you for your in-depth the presentation and answers. And well, there are more thank yous right here.
You're welcome. You're welcome. We are all here to answer your doubts. It is the first time for me participating in this event, and I am happy for being here. And thank you again, Caroline, for inviting me.
We are definitely happy to have you here with us tonight. It has been definitely a very good presentation, and you've done a great job, that's for sure. And I just want to answer one of the questions from the patient, which I should answer. It's about the, well, it is being recorded, okay? So we will definitely upload this webinar within the next few days. We are definitely working hard, but as you know, there are 2 events every single day, so we just need more time to upload all the videos, but it will be there. Okay, if you subscribe to our YouTube channel, you will be updated when it's actually on our website. Okay, again, thank you so much everyone for joining. Happy that you found it useful. And well, Dr. Vanessa, have a lovely evening. Thank you so much for joining us, and it has
Thank
been a
you.
pleasure. Possibly we will be able to do it again. It would be really good. I mean, you know how it works now, so I guess it's not scary anymore, right?
No, not at all.
That's great to hear. Excellent. Thank you all so much, and well, have a lovely evening, and hope to see you tomorrow at 6 p.m. and 8 p.m. UK time as well. Good night.